Hey everybody, welcome back to the ECG of the day. My name is Reid, and let's jump into this rhythm. So, first step as always, we're going to look at the forest, and the forest is consisted of, or is made up of the trees, and the trees are our QRSs. And so I like to just maybe pick a rhythm strip here at the bottom, maybe lead 2, and I see I've got what seems to be a narrow complex QRS. I'm just getting a gist of what's going on. I'm getting a regular rhythm here. So just look along. Okay, I see this pause here, so there's some pause. And I scan through, I see my rate. This QRS ends on a solid line, so 300, 150, 100, 75, 60, somewhere maybe 65 beats per minute. And so go ahead and note my pause, like we said, and so we've got a narrow QRS. Let's see what the atria is doing. So look for a P wave. I see P waves here that generally seem to occur in front of all of these QRSs. My P waves are, if I look at lead 1, I would say those are upright in lead 1, upright P waves in AVF. So that means that this is a sinus P wave, which is important to make sure that this atrial depolarization is coming from our sinus node. Next step I like to do is evaluate the next step down in our conduction system, which would be atrial depolarization now to our AV node. Our AV node is measured by our PR interval. And if you see, I like to find a QRS that begins on a solid line. I would say that perhaps this QRS begins on a solid line, and if I look back, this P wave begins at least by that next solid line, so that is within, even though it's barely within 200 milliseconds, so that is a normal PR interval. My QRS duration seems to be narrow, like we said. It's less than 120 milliseconds, so that our QRS is narrow. And I like to measure my QT interval. I just eyeball it here. You know, a good way to eyeball it is to pick R to R intervals. So if I pick here in V5, R to R, our T wave should end by the midway point. And so that's just the eyeball test of my QT. And so those are looking okay. Next thing we'll do is the next step in our conduction pathway. We've evaluated our atrial depolarization. We've evaluated our PR interval, our AV node. And now let's look at the QRS. My QRS axis, it's isoelectric in lead 1, so that means it's perpendicular to lead 1, and it's upright in AVF, so that means my QRS axis is going straight down, so that's a normal axis. It may be almost rightward, and as I scan through, I like to look for good R wave progression through my precordial leads. What I notice here is if I zoom in to lead V1, I've got this kind of funky looking QRS complex that almost looks as if it's an RSR prime. An RSR prime. And so I would say that this is an RSR prime morphology in V1, which makes me think, is this a right bundle branch block? Well, we said our QRS down here, we said our QRS was narrow, so it can't be a right bundle branch block. Maybe it's an incomplete right bundle branch block. We've got the RSR prime in our kind of anterior chest leads that are measuring our right ventricle, measuring those R prime late signals to the right ventricle. And even if you look at our lateral leads over here in lead 1, lead AVL, we've got these slurred S waves, which are representing maybe some slurry late signals going away from the lateral leads, which would be towards the right ventricle. So that gives us even more data to say, yeah, maybe this is an incomplete right bundle branch block, right? And even in V5, V6, we can see those slurry S waves. So I am on team incomplete right bundle branch block. And so the last step that we would do for this rhythm is we are going to kind of scan through our anatomical leads and look for, as I have done here in our kind of some tips here, pathological Q waves and ST and T wave changes throughout, which I do not see any deep Q waves, which would be pathological for a previous myocardial infarction, and I don't see any ST or T wave abnormalities. And so now we need to look at this pause that we said we had this pause down here. And so when I see a pause, you have to have an approach. In medicine, you need to have an approach to a pause, right? And so over here in my important takeaways, I've got pause. And so what I need to do is figure out, is the pause due to the sinus node? Is the sinus node either 1, stopping, or 2, is it premature? So like a premature atrial contraction. Or are we, say, having an AV node issue, right, where we're not conducting signal down to the ventricles, right? So we could have a premature atrial contraction that is blocked by the AV node. So we could have AV blocks, just general AV blocks. And so that's just the first thing that comes to my mind, especially when we already have identified this as a sinus rhythm. What about the underlying sinus rhythm is not going to work for this one beat? It's only just one beat, and there's no pattern to it. And so when I look in here, what I want to do is I want to determine, did the sinus node stop or not? And so what I do is I'm going to pick V1. I'm going to pick this rhythm strip here. And I'm going to look at the pattern of the normal depolarization and repolarization. So I look here, I see my normal P wave, my normal QRS, and my normal T wave, right? This is kind of a flat little bump of a T wave. And I compare that to the previous set, and I say, okay, I have a good idea of what this looks like. Now let's go ahead and approach this pause. So I've got my PQRST, PQRST, and then my pause. And I say, okay, what is different? Can I look in front of the pause and say that there is a difference? And if you zoom in on our T wave here, you can see that the normal T wave in the previous beat is just this smooth, but this T wave has, instead of it being smooth, what you've noticed is it's got this notch, that sharp notch, and that notch is an atrial depolarization. That is a premature atrial contraction that caused atrial depolarization. And so we think of PACs. Well, PACs, why did it not create a QRS? Well, in this case, what we're seeing is we had a premature atrial contraction that was blocked. So a blocked PAC. Well, what blocked the PAC? Our AV node blocked the PAC. Right, so if we come up here to our heart and just think it through what that looks like here in the top left of our screen, our sinus node is going to beat normally, in a normal fashion. It's going to depolarize the atria. The AV node is going to capture that signal and send it down into the ventricles to get ventricular depolarization. And while some of the AV node is refractory, we get this early premature atrial contraction from somewhere else in the atria. It depolarizes the atria, but the AV node was not ready yet. And because of that, the AV node was unable to conduct that signal and blocked the signal. And so that's what happened. And so that's explaining our pause. And then you see at the end of the pause, our P wave picks back up, conducts to our QRS, and we're back into our normal rhythm. So let's put it all together here. We've got our sinus rhythm at a rate of 65 beats per minute. We've got an incomplete right bundle branch block with our RSR prime in the setting of a narrow QRS and our slurry S waves and lateral leads. And we've got a blocked PAC. So hope this EKG helped you guys. Remember, having a systematic approach to EKGs is the best way to not miss anything important, and try to make sure that you can explain your patient's symptoms based on the EKG. So with that, have a great day.